Well, hello and welcome everyone to this Ask the Expert. This evening, my name is Paula Hamford. For those of you who don't know me, I am the CEO of PSC Support, and in the background helping us, we have Martine Walmsley, who's the head of research strategy at PSC Support as well. All of these recordings are on our YouTube channel, so if you'd like to rewatch it, it'll be available there in a week or so. And this is a very popular session. We've had 93 people register for the session, so we understand how much people want to know about the symptoms and the routine care that PSC, those affected by PSC face. I am absolutely delighted to be joined this evening by Dr. Simon Rushbrook. I know really busy, so we're very grateful for you for giving up your time this evening.
It's a pleasure.
Dr. Rushbrook is a consultant hepatologist and clinical lead for hepatology at the Norfolk and Norwich University Hospital. So as I mentioned, today's session is going to be on PSC symptoms and routine care. So please I know there's going to be lots of questions. We've already, before the webinar even started, I think we've had about 12 to 15 questions. So we know there's going to be lots of questions, but Dr. Rushbrook is going to take us through a presentation, and then there'll be plenty of time for questions at the end. So that's all I'm going to say. As always, no, I am going to say one more thing. As always, Dr. Rushbrook cannot give individual medical advice, but obviously we'll try and answer your questions in the best way possible. So thank you so much for joining us, Dr. Rushbrook. Thanks again for giving up your time this evening, and over to you.
Can you see my slides okay?
Yeah, fine.
Lovely. Okay, we'll make a start. So thanks for the invitation. And I'm going to use the next half an hour just to try and take you through really the topics that I'm going to try and answer. And I think just, I know we'll have patients at various stages of their journey, just recently diagnosed, and patients that know a lot of information, but I thought it's always helpful to set the scene about this topic. So what is PSC? Let's just remind ourselves about that particular aspect. Well, for me, I still think it is a autoimmune disease, and that's what I think all the genetic and immunological disease and evidence points to. And what that means is that our immune system that's normally should be defending us from the outside world turns inwards on us and attacks us. And in this particular disease, it can attack two particular areas, that of the bile ducts and the biliary tree, but also can obviously affect the colon for those patients that have associated colitis. So really, with that in mind, obviously one important aspect of clinical care is bearing in mind when you see patients with PSC is, have they developed potentially a new onset autoimmune disease? And of course, not all symptoms mean it's PSC related. It could be a new symptoms related to the development of thyroid disease, or if someone's got new bowel disease, for example, and diarrhea, having had quite controlled colitis, they may have new onset celiac disease. So something always to be aware of, the onset of new autoimmune diseases in coexistent patients. And like most autoimmune diseases, we think they come around because of the interaction of our genetics, our DNA, and more importantly, something in the environment triggering the disease. And just to remind people, it's a very rare disease. It has NHR rare disease status. It's slightly more common in males than females, we think, and it tends to represent and occur around the ages of 30 to 40. And it really represents one of 4 autoimmune diseases that we look after, which include, alongside PBC and autoimmune hepatitis. One thing patients often ask in terms of symptoms and management and coming to the clinic is, if there is a genetic component to the disease, can my children be affected and should they be screened for it? And the answer to that is no. You know, this is not a monogenic where you have one gene causing the disease. This is a different sort of disease called polygenic disease. And that's one thing we don't advocate, that children are screened for PSC or colitis. So that's one of the first things, as well as I say, looking out for those other autoimmune diseases in clinic. So to remind us what's under attack in PSC, here's a little screenshot of the liver just to remind you. You can see that green bile tube draining the bile that's made out of the liver. And that's the principal tube which divides like branches of a tree inside the liver that's under attack by those cells of the immune system. And you can see that a bit closely there outside of the liver. And remind you, the bile duct's divided into a bit outside of the liver, which we call the extrahepatic biliary tree, and the bile ducts inside the liver, which we call the intrahepatic biliary tree. And those are the site of that autoimmune attack. How do we see those bile ducts under attack? Well, historically, we had to basically, the way you showed bile ducts is you used to put a camera inside the stomach called an ERCP, and we used to squirt dye up the bile ducts to outline the bile ducts to see if they were diseased and damaged. And that's a little cannula going in the bile duct there in the bowel, where you would squirt some bile up, squirt some contrast up the bile duct to show its appearances. And this is a sort of typical normal bile duct. That's the extrahepatic biliary tree I just described to you. And you can see the bile ducts dividing like branches of a tree inside the liver. And there's the cystic duct, which goes into the gallbladder, where you store bile in between meals. And of course, there's many ways of imaging the liver. We can do an MRI, we can do a CT and ultrasound, but really, we don't want to be subjecting patients to these invasive tests to outline their bile ducts. And the way that we diagnose PSC now is we do an MRI scan called an MRCP. So in terms of your diagnosis, this is how a lot of you would have been diagnosed by having an abnormal MRI scan. And you can see that the bile ducts do really become injured and scarred and look very irregular and damaged for some patients during the course of their illness. And of course, another important job during our clinics is to make sure that we've got the right diagnosis. This appearance, which occurs in PSC, can happen with many diseases of the bile duct. So one thing that happens often at the start of a patient's journey is being absolutely sure we've got the right diagnosis. And that's often based on excluding other things. Unfortunately, there is no diagnostic blood test of yet to cause that diagnostic certainty 100%. And of course, we need to remember that some people, those bile ducts that are injured in PSC, it's not just the big bile ducts, but it's the little tiny bile ducts in the liver. And therefore, to diagnose that group of patients, you can't do an MRI because their big bile ducts look normal. We have to do a liver biopsy where the little bile ducts of the liver we can see injured. And this is a sort of representative liver biopsy showing some classical changes that you tend to see in PSC. And as I said, about 70% of you will have colitis. So of course, when you're seeing your clinicians in clinic, of course, sometimes people will see a liver doctor and a separate bowel doctor in conjunction in their clinical care. Sometimes those two things are combined into one consultation with one doctor, and different units work differently. And of course, that really means that we have to be dealing with all of this during a clinic consultation. One also obviously important aspect, therefore, is making sure that colitis, is it, and documenting at the start of a patient's journey, is it present or absent? And that's why all patients we recommend have a colonoscopy at baseline. And if you don't have colitis at that first endoscopic procedure, so you're one of the 30% who don't have it, it's important that your doctor keeps checking at intervals. There's no real study telling you what's the right thing to do, but a lot of national guidelines and international guidelines suggest that perhaps a repeat colonoscopy every 5 years, or if you develop new symptoms that mean you could have developed colitis after your initial screening test, you should undertake. So what's all the consequences of this? Because this all really leads into the thing that we need to talk about, symptoms. I think the first thing to always remind everyone is everyone's unique. Everyone has different progressions of disease. Some people stay with a very mild phenotype. That means a very mild PSC, where some people obviously can develop a very severe and pronounced PSC with very demanding symptom burden for the patient. And I think that's the first thing to say. Everyone's unique, everyone's different. And I think it's important when we're discussing these things to remember that they don't all apply to you and may never apply to you. The first thing is, as I've alluded to, that as these bile ducts get inflamed, and as these bile ducts are attacked by the immune system, they become very scarred, they become very irregular and very damaged. And there's two consequences to that. The first consequence is that bile, which is normally meant to flow down these tubes beautifully, gets interrupted and doesn't flow as well. And doctors often use in the clinic this term cholestasis to sort of use or describe that sort of alteration in bile flow. The other consequence is that bacteria can proliferate in these tubes and start to become more pronounced. and can cause infections, and that's often what doctors call cholangitis. So of course, one important thing that's really important, and I think, obviously, PSC support have generated cards on this and done a lot of work on this, is making sure that you are vigilant to know that if you get pain in your side, you start getting fevers and shakes, you may or may not go yellow, that you may be developing an attack of an infection. And of course, one thing that we really do want to get across that is that people with large duct PSC have a course of antibiotics at home to start as an emergency, just in case, because it always seems to happen on Saturday night when you really don't want to be going to the A&E department or you've got a long wait. And it's really important that you report that to your medical team if and when it happens and you've had to take a course of antibiotics. So I think one important symptom that often doesn't coincide with clinical care, but happens in its own right independently, is the beginning of symptoms of cholangitis. The other thing is, of course, if bile's not flowing well, there's alterations in bacteria in the bile ducts, that's really a setting scene for the development of stones. And you can form little stones sometimes in PSC in these bile ducts. And of course, you can also form little stones in the gallbladder, which can migrate and move into here. And of course, the development of episodic pain or new pain doesn't always have to occur with a bacterial infection, cholangitis. So if you get sudden attacks of pain, it's always also worth thinking about PSC. Could I be having stones formed, and could those stones have gone into the bile duct and have the appropriate investigation? So two important symptoms, stones and pain, and obviously infection and attacks of cholangitis. And once again, if this bile flow really does become interrupted, then of course a patient may present with jaundice, which is obviously where the most telling sign is that the eyes go yellow first, the urine often starts to go dark, and the stools go pale. The other important symptoms about this lack of bile flow through the liver, which we call cholestasis, is it often is very much associated with pronounced fatigue. And really, you would hope in your clinic appointments, your doctor's quizzing you on that and trying to make some assessment with you how that's impacting your life and how you might make practical adaptations to manage that. In addition, if you get a flowing of bile through the systems, you often can develop itching, and itching is something that we see. And it's quite unusual. In fact, it's interesting that often this occurs in waves in my experience. People just get a bout of itching, but equally sometimes people can get protracted itching. There is a pharmacological, that means a drug therapy line that we tend to use that have been advocated by various bodies. I think the real important point from your doctor is to understand what those therapies are potentially could be offered. Are there any obvious reasons why you shouldn't have a particular drug because it might interact with other drugs that you're taking? There might be a good reason why you can't take it. And also understanding whether the drug you're about to take interacts with your other medication. These are all checks that need to go on outside of the clinic once you talk to your doctor about itching, and things that need to be considered. The other thing, of course, that if bile isn't flowing well into the bowel, then you might get some malabsorption of vitamins. This is particularly in people that are very yellow and jaundiced, so often in people that are waiting transplants. But it is really important that your doctor's measuring your vitamins that need to be absorbed by your bile, or help in the absorption of bile, what we call the fat-soluble vitamins. So really, people waiting for transplantation, you should be checking their vitamin D and their vitamin A, because some of these things can have consequences if they become very low. In line with that cholestasis as well, and it's not just a low vitamin D that's driving this, there's something about cholestasis in the liver. Bones can become thin. They can basically go from this architecture where you have very solid bone in here, this is called spongy bone, but you can see that all these little ridges are very thick, to these very thin spongy bone with lots of holes. This is osteoporosis. And of course, osteoporosis isn't a disease as such, but what it is a state that increases your risk of fractures, particularly if you were to fall or injure yourself, or which can happen spontaneously in the spine. And that's why really another important aspect of clinic care is making sure that patients have had some form of assessment for osteoporosis, i.e. a DEXA scan, and making sure that you've screened and treated for it appropriately, as well as making sure people have a healthy intake of calcium and vitamin D. Now, of course, the thing that can happen for some patients with PSC ultimately is the liver can transform from this healthy substance into progressively into developing cirrhosis. And cirrhosis is really defined by nodules of liver tissue surrounded by bands of scar tissue. Now, there are signs or often risks for progressing towards that more severe phenotype. And once again, I want to just reiterate, not everyone will do this. A lot of patients will stay at the mild end of the spectrum and some will progress. But there are things that we look for in clinic that might indicate a more likelihood of progressing over time. They give me some idea about where we are. And some of those things that often we look for to see if someone is progressing. So how can you work out if someone is progressing down this pathway of scar tissue? Well, there are some clues. For example, the liver cells in cirrhosis start not to work as well. So if someone has a falling albumin, which is a protein made by the liver cells, that might tell us the liver's not doing so well. Clearly, if they're developing progressive jaundice, which is really jaundice that's arisen because the liver as a whole isn't doing well, rather than the tube has become physically blocked at one point. That could be a worrying sign. And of course, another thing that the liver makes is clotting factors that help your blood clot. So if the liver cells stop making these, of course, your clotting tests might slowly become abnormal. So of course, the one guide to me how things are doing is these things here. But these are obviously very late stage markers of the liver starting not to work as well, which might indicate a patient might potentially be heading towards liver transplantation. Of course, the other thing which is important is the shape of the liver, because clearly as you develop cirrhosis, the liver can become bumpy. And the other thing is, as a liver becomes more stiff and more scarred, blood doesn't get through it so well. So the consequences of that is that the blood behind the liver starts to congest. And as a consequence of that, because blood's not flowing this way beautifully, it's starting to congest. It's like if you like a roadwork, the cars don't move so well and traffic starts to congest. And one consequence of that is the spleen starts to get bigger. So another important thing that we look for and monitor for in clinic is spleen size. And when the spleen gets bigger, it starts to trap platelets. So as the platelets start to fall, this really could indicate that a patient is developing changes in the blood flow of the abdomen as a consequence of liver disease, which doctors call portal hypertension. And there are important things that can happen in portal hypertension. For some people, and once again, I stress some, they can develop fluid in the abdomen called ascites. So if a patient suddenly started developing a swollen tummy in between their clinic appointments, there are other reasons for a swollen tummy. It doesn't mean that you've got this condition called ascites, but you should be informing your nurse specialist and your consultant. Also, when you start to get these changes in blood flow in the abdomen, you can start to form these abnormal veins in the gullet, which unfortunately can bleed, as shown here. This is what we call a variceal bleed. And one important job we have in the clinic is working if a patient does or doesn't have this thing called portal hypertension that may or may not put them at risk of varices, and looking with a camera to determine if they are present or not, if we feel that could be the case. And if we diagnose them before they bled, there are things that we can do to reduce the risk of bleeding. We can put them on drugs to lower the pressure in those veins to stop them going pop and bleeding. And sometimes we have to put little rubber bands on them to get rid of them in a course of what is called variceal banding. So another important aspect to care, looking for the presence of complications of changes in blood flow called portal hypertension. And of course, another aspect of care is really obviously looking and determining, is a patient at risk of or needing liver transplant based on a number of factors, which are often driven by a combination of either symptoms or driven by a combination of how well the liver's working. So sort of coming back to how can we get a feel how stiff and scarred one's liver is? Well, there are many ways. We don't just have to rely, as we often did in the old days, of doing biopsies. We have now these range of techniques and markers, which we call non-invasive tests, because they don't involve a biopsy, of assessing how a liver is scarred. So another aspect of care is that at intervals, and we could talk about those, but often guidelines talk about every 2 or 3 years, Patients should be having an assessment of where they are on their scarring journey to give them some idea. Are they staying at the good end? Are they progressing? Could things be changing in the future for them? And there's different ways of doing that. You can do a simple blood test, which looks at some things which are altered when you get scarring in the liver. This is called an ELF test. And obviously, as the scarring level goes up, the ELF score goes up with it. So this is a test, a simple blood test. The problem is not every center offers this, okay? And therefore it is center dependent. It doesn't mean that's wrong if your center doesn't offer that. This is just the technique your center has decided to use. The most commonest thing that most patients though use is this test called a FibroScan, which is obviously where we put a probe on the liver and determine the amount of scarring in it. And we get a little number as shown here in kilopascals, which gives us some idea as how much scarring you've got. And obviously as the number goes up, the amount of scarring goes up. And you can see here's some examples. Here's the levels of scarring in PSC, F4 being cirrhosis. You can see that the number goes up as the degree of scarring goes up. So once again, there's no evidence to say how often it should be done, but most people, every couple of years, 3 years, depending on what guidelines you read, is not a reasonable undertaking to make that assessment of where a patient is on their scarring journey. And there are more fancy technologies, but most people in NHS won't have access to these in routine clinical care. Another important aspect about symptoms is an assessment at every opportunity when you see the patient is about their colitis. If you're seeing doctors that are looking after your liver and your colitis, and you have colitis, we need to make an assessment of those. And what I want to remind people here is there is now a wealth of treatments that are used for patients that have coexistent inflammatory bowel disease of the colon. There's many of these are written here. Now, the problem with all of these drugs really is that when the trials are done of people with inflammatory disease without PSC, PSC patients are never included in them, and therefore we have to develop as a clinical community and individually our own take about the safety profile of these drugs in our patients with PSC. And therefore there is a range of these drugs, and really often now what you should find in what I would call more modern disease management is patients are under both a liver specialist and a bowel specialist if they have both conditions, and that those two doctors talk to each other. Hopefully, if your IBD is getting worse, your hepatologist along with your IBD doctor decides what's the right treatment for you and the right approach for you. I think we'll probably get a few questions of this. I suppose one question is, should patients be on any treatment for their PSC? And we have to be honest that there is no, as of yet, treatment that's been shown to definitely change the natural history of the liver disease of PSC. But what I would say is an old-fashioned treatment called ursodeoxycholic acid often does make the liver test better, but whether that translates into a change of clinical outcome or changing a patient's natural history of their disease, we don't really know. I think this has come full circle. There was a phase where people were very anti-urso, and that you'll find different experts have their own view on that. Being as it really is, in my view, a harmless drug if used at the right dose. You don't want a big, massive doses where we think it might do something deleterious. But if you use it at the right dose and it makes a change to patients' blood tests, then it's not an unreasonable thing to do if you're not thinking about putting the patient into a trial or doing something else. I think that my take-home message is it's something you discuss with your doctor, and between you and your doctor, you work out what's right for you. And that's why the recent European guidelines said it kept it open, the question of giving urso. It didn't say you shouldn't do it. It's a discussion between the patient and the clinician. I know it's always a very difficult thing to talk about, cancer surveillance, but it is an important part of your clinical care because unfortunately, at these sites that are chronically inflamed, the colon, the gallbladder, the bile duct, we know in PSC there is an increased risk for some patients of developing cancer. And what I would say to you, it's really important for those that have colitis that you're getting your annual colonoscopy or an interval you and your doctor have decided is right for you. Trying to pick up early changes that could lead on to colorectal cancer and treating them endoscopically. I would remind you that also as part of that, if you've got a pouch, we should be inspecting your pouch every year. So if you've had abdominal surgery and you've had your colon removed, but there is a pouch remaining, make sure you get your pouch surveillance as recommended by the BSG. For bile duct cancer surveillance, the guidelines vary and there is no standardized approach, but you want to be at least if you've got cirrhosis of the liver, and this is important, we want to be scanning that liver every 6 months by some means. And if you don't have cirrhosis, we want to be scanning your gallbladder and probably looking at your bile tubes as well in the interim with some form of scan. And once again, that's center dependent. It does depend on the specialist. So, some general points which we forget about often in clinic, particularly directed for our female patients. I think, pregnancy is safe in PSC. There are some things we're beginning to learn about the risk of itching occurring. But generally for myself, when I have patients with PSC who talk to me about starting a family, I want to make sure this is, once again, it's all about joint care, joining things up, making sure you go to a pre-pregnancy counseling clinic and making sure we thought about everything, which is not just about PSC, but also dependent on the stage of disease. And for non-advanced PSC, the use of oral contraception is considered safe. There are general other things about clinic care that's really important. We want to talk to you about your quality of life, how all these symptoms and things I've discussed are impacting you. And also in making sure for some people, not everyone, it can have an impact on their mental health, and thinking about trying to how we address that in clinic and help you with that. I think like most people, we're all busy people, and getting hold of doctors and GPs is becoming incredibly harder in the NHS. And that's why having a really good nurse specialist, either through IBD care or through liver care specifically, really does make a difference in my view. And if you can or are lucky enough to have a nurse specialist, that really is a great point of contact, to have those email addresses to contact your specialist on time. Vaccinations are safe, but you do need to look at what other drugs the patient's taking, because some immunomodulatory therapy could affect it. But always talk to your doctor about what vaccinations they would recommend. And I really think for all patients with all chronic disease, high-level information, we're very lucky that PSC support has some excellent medical information for you. But it's also important that that information is right for you. For some people, that can seem very overburdening and overwhelming. You've got to take on the right amount of information for you. And the most important thing is that between your clinic consultations, report change. Don't wait for your 6-month, 12-month, over-month review, okay? If you've got new symptoms of itching, jaundice, you've got attacks of pain, cholangitis, unexplained weight loss, change in your colitis symptoms, we need to know about it, because that might tell us something changing in your disease that needs new investigations. It can't wait until you come to clinic and see us. So please report change. Finally, always at those clinics, make sure we're talking about trials with patients, making sure every patient has an opportunity to do a trial. And really what I want to summarize from this is symptoms drive a lot of parallel clinical care we do. We're looking for those autoimmune diseases. We're looking for how the diagnosis was made and being sure we've got the right diagnosis. We're assessing that fibrosis in clinic. We're doing appropriate cancer screening. We are hopefully offering a very patient-centered care. And we're also remembering everyone is different. Everyone can take on information at different rates. And remembering that some of these scary things that we talk about don't or will not happen to everyone. They are for few, but it's important that we look for those in patients where it occurs. So I'm going to stop there. I hope I've stuck to about half an hour, and I hope that was a helpful overview from me. I'm sorry I probably haven't covered everything. It's a very superficial overview, but I've tried to give you some idea about the things that are important in clinic and talked about some of the symptoms that can crop up and how we think about them. So I'll stop there and stop sharing. So there we go.
Thank you, Dr. Rushbrook. I mean, that was 30 minutes exactly, and I think everybody will agree, a very clear, there's lots of hands clapping and hearts going up, so a very clear explanation of PSC symptoms and what you should expect from your routine care. I've got loads of questions, so I'm going to jump straight in.
Go again, let's go for them.
The first group of questions are on symptoms.
Mm-hmm.
The first question is about fatigue. Can you get fatigue in PSC, even if you've just been you've not had PSC very long, so you've just had a recent diagnosis?
Yeah, I mean, I think we've talked about fatigue before. I mean, fatigue can occur at any time. Now, there is no doubt there are some people who have chronic fatigue, as in what I mean, it's constant. It doesn't seem to fluctuate. And there are people where the fatigue, I think, is related to some alteration in something's going on in the liver that's, if you like, exacerbating the fatigue. I think fatigue is it's a it's one of the most debilitating symptoms. The reason it's debilitating is we don't have good treatments for it. I think in terms of general approaches though to fatigue, it's always to acknowledge it. It is real. It's not in your head. It's trying to talk to you, your family, your loved ones, your employers about how that's impacting you and how you might have to make adaptations to manage that fatigue. I think it's important to make sure there isn't something else going on and it doesn't all get blamed on your liver disease or your colitis. Because as I say, sometimes people get thyroid disease, which can present with fatigue. Sometimes they can develop anemia from their colitis. What I mean is make sure you really look for all the things that your disease could drive that could be treated, which might be making your fatigue worse or even causing your fatigue in their own right, and treat those. So I think the thing for me is about making sure the patient understands it's real, it's not made up. Often it's not going to be improved by sleep, and it's therefore trying to adapt your home, your work, and your loved ones needing to understand it. Make sure you've crossed all your T's and dotted all your I's in terms of the disease itself. That's something you can't treat, a particular aspect. And then make sure it's not something unrelated to the disease that's driving it. And those are the general approaches. And really, in conjunction with your GP and your specialist, that's what they should look at.
Thanks very much for that. Another question about symptom, and that's itch.
Mm,
The question is this: if itch is present with normal range liver bloods,
mm.
it still be associated with PSC?
Yeah, no, I mean, once again, and I'm sure a lot of this audience is aware, I mean, there are many causes of itch. Okay. So, for example, iron deficiency can cause itch. So my general approaches is make sure, first of all, you've ruled out non-liver itch, okay? And also make sure you haven't got a simple dermatology condition like eczema or something that can be treated. Don't be fooled that you have to have abnormal liver blood tests to get itchy with liver disease. I have lots of patients who have severe marked liver itching. They have normal liver blood tests. There isn't a perfect correlation. Although the one thing I would say is often my observations in clinic is that often when someone's gets something going on, like maybe they're developing a tight narrowing in the bile duct, that often that's when the liver flow of bile reduces and the itch goes up. So of course, what it should be a marker of is for you as the doctor, often thinking about if there's a new attack of itching, understanding it. You might want to do a new scan to make sure there's not something going on that's changing for that patient. But don't be fooled that you have to have abnormal blood tests to have liver itching. Okay.
Thanks very much for that. The other question on symptoms I have at the moment is about upper abdominal pain, which
Mm,
we know is associated with PSC.
mm.
And the questioner wants to know that they have varying severities, and they just want to know about ways to treat the different levels of that pain.
So I mean, once again, first of all, it's making sure as best we can we understand it. So, I mean, I think as you alluded to, Paula, there is certainly a group of patients with PSC where pain is a very predominant feature, and you just can't find a cause for it.
Mm.
I always want to make sure with anyone with new onset pain that we have done some imaging. We've made sure we're not missing something. But I think the major thing is that occasionally, in my experience, also stone disease. And the problem is with PSC is they often form tiny little stones in the bile ducts. They're often stones that are hard to see on an MRI scan sometimes. And to be honest with you, I've had quite a few patients over the years where we've done an endoscopic ultrasound, where we've looked at their bile duct with ultrasound from inside, and we found little stones that we don't see on MR scan or CT or another thing. So I think there is also what I suppose I'm getting at here is you really want to make sure you've done proper imaging to make sure you're not missing anything. You want to really make sure for that patient we're not missing little microstones that could be treated. And then for those patients where you just can't come up with another explanation for it, well, most of the time we end up using an analgesic ladder, which whether that means regular paracetamol, some sort of mild opioid, those sorts of approaches. But it is hard sometimes, and making sure that there's not something else going on. obviously, like all pain, when people are feeling a bit low in their mood, that can make things worse. It's making sure that we need to treat everyone or every other symptom that could be compounding the pain. So I think looking at mental health, making sure everyone's had imaging, making sure we're not missing stones, and some sort of appropriate use of an analgesic ladder where you're going up in strength sequentially is the right approach. But there are for some patients where we can't, we just don't seem to be able to get on top of it, and that's always a very difficult symptom.
Yeah, it is. Next set of questions is about medications.
Hmm.
So the questioner asks, my son has been taking Pentasa since his
Hmm.
diagnosis 21 years ago.
Hmm.
And they said, that I know there have been many debates on whether this is still the right treatment. He's been relatively well, thankfully, and with just a small number of serious flare-ups. But what's the latest thoughts on this medication? And have there been any new drugs that could replace or might be better?
So the honest answer is, I mean, is once again, I mean, the honest answer is no in PSC specifically. So I think I can answer that. I think my own view to this often is that there is a thought that Pentasa might reduce flares and might. There was a feeling for a long time whether it might prevent colorectal cancer, and then a lot of patients end up on it to try and help keep their colitis quiet. I think if you're a patient that's been on it a long time, I think always discuss it with your doctor whether you want to come off it. That doesn't mean you should stay on it. But I think a lot of the time, in reality, if someone's well, you sort of think, well, why would I go tampering with something? And potentially, if that upset things, it did make them flare. I think what I can say to you is I'm not sure we have evidence in PSC it reduces the risk of the lining of the colon turning precancerous, which we call dysplasia, and turning into cancer. But for a lot of patients I have with PSC and colitis, I do put them on it, thinking it might reduce inflammation and therefore might stop them progressing and might keep their colitis more quiescent. And so I think a lot of people use it. In terms of different drugs, well, there are different brands of that sort of class of drugs. Some of them have a reduced pill burden, i.e., you take them once a day as a long acting preparation. So I think it's always worth speaking to your doctor if you find that you're taking some medication twice a day. Could I switch to a brand that's long acting, which just reduces the pill burden for a patient and might also reduce the frequency? I'm rubbish at taking my medication. I'm very honest about it. I forget my statin at night. If you get that tablet down to once a day, you're more likely to take it. So just reducing pill burden and compliancy. So that would be my thoughts on those things.
Yeah, thanks very much for that. We have a question about oral vancomycin.
Okay.
Please, could you discuss the controversy over the use of oral vancomycin therapy, especially in the light of the Danu paper in 2020 that states it does not work? So there's been varying explanations for this, isn't it? Sometimes people say it works, and some papers have said it doesn't work. Sorry if I'm pronouncing this wrong. The RECU2 paper that recommends it for PSC IBD, and the just published Kellermeyer paper that states that the therapeutic window is early in the disease process and that oral vancomycin is a potential therapy. What are your thoughts on that?
Yeah, I mean, like most people, I've read these things, and I think my own view is we don't know. All right. And I think there's lots of people that have a view on this thing. Obviously, I know a lot of the noise and the literature is really focused around the pediatric setting, isn't it? I think my worry, and I'm being honest with you, is this is an antibiotic, you know, and I still worry that taking an antibiotic long term might lead to resistance of enterococcus, which is a potential pathogen of seriousness if it gets resistant. You get VRE or some sort of resistance profile. I just worry that we don't have long term data to show it does any good in patients, and I really do worry that what are we breeding by giving it long term? And I think there is a real danger that I do believe in some patients, more so in the pediatric and the adult setting, it helps the colitis, and I think there's lots, and I think it does do something. The question is it really safe to give a long-term antibiotic to those populations of people so young? And I just don't think we know. And I think anyone who says to you they do know is not being truthful. That's why I think when I compare it to other medication, and I know we talked a little bit about URSA and stuff, it's been around for so long, and I think while we we know a lot about that. So I think there's a danger with vancomycin. I don't personally use it in my patient population. Is my own, if you really want to know what I do, because I just don't think I know the safety profile long term. Okay, I think it's a really interesting area, and of course it may work in a number of ways. It may have an effect on the immune system, it may have an effect by altering the microbiome, it may even affect colonic cell function, but we just don't know. And I think when you don't know, to dish out a therapy to a young person long time. But I know there will be people, and there will be stories of people whose colitis has got better and it's saved their colon, and it's really hard. And I think it's therefore, once again, it's something, if you're faced with that and you're a young patient, to discuss with your doctor. But you do have to be honest with people.
Yeah, thanks very much. It's a question that comes up time and time again. So thank you very much for giving your point of view on that. And there's a question here about somebody who's becoming increasingly anemic.
Mm.
And it's never been something that the hospital consultants talk to them about.
Mm.
And the question is, how does the person best get advice and care for this? Do they keep trying their GP, or should they ask for a referral to another service?
Once again, always difficult to comment on an individual case.
Yes.
Anemia in general, in PSC, if we're trying to generalize it. I mean, obviously the first thing is that, is it something simple? Are their iron stores low because they have colitis and they're bleeding microscopically or overtly with stool in the blood? It is possible, of course, that they might have a coexistent disease. So iron deficiency is a very common way with celiac, and of course celiac's associated with PSC. And of course, some patients with PSC develop a disorder where their immune system attacks their lining of their stomach, and you don't make acid. And if you don't make acid, you can't absorb iron as well. So the first question is it iron deficiency? And trying to understand the mechanism of that. Okay. The other thing, of course, is that it could be B12 deficiency. And of course, I just spoke about an associated autoimmune condition that you see with anemia, that you see with PSC, whether you attack the lining of the stomach. And that also doesn't just result in iron problem absorption, it results in problems with B12 absorption. So first of all, really, the first question is understanding, do I have iron deficiency, B12 or folate deficiency, and how and why has that occurred, and does it relate to my disease? Another reason why people can become anemic is as the spleen gets bigger. Remember I talked to you about the alteration in blood flow through the liver. As the spleen congests and gets bigger, not just that the platelets get trapped in that spleen, but also the hemoglobin can get trapped in that spleen. So often as PSC advances and you find the spleen size going up, you also find that the hemoglobin level starts to drop and go down. So it could be a sign of progressive PSC. Could be. I'm not saying, because I don't know this patient's individual case. Mm. And of course, there are things that are completely nothing to do with that. Sometimes people can be anemic because their bone marrow is not working. They might be breaking down red blood cells at a faster rate. I mean, I suppose if someone's worried about it and they don't feel like they're getting the answers, of course, they could go and see a hematologist who's a blood doctor and get a formal opinion about the hematologist. Well, GPs often deal with anemia. They should be able to get the basic investigations done to help determine.
Okay, that's great. Thank you so much for that. There's a question here about staging for PSC patient. Do hepatologists normally stage for a PSC patient? If so, what are the tests used to stage?
Yeah, so staging is a term that we use to really say, well, how bad's the scar tissue? That's what we're talking about. And I sort of alluded to that. I mean, I think you should be being staged intermittently, and most guidance suggests an order of interval of 2 to 3 years to have a look and see where things are. I think in most centres now, most patients are undergoing FibroScan, because FibroScan is very common in most hospitals now, in most hepatology clinics. Some centres may choose to use that blood test to tell you how scar delivery is, called ELF. And as well as, if you remember, when you're having your annual or 6-monthly scan, you're going to see if that liver's getting irregular, which might suggest it's getting very scarred, the liver, or if the liver's shrinking in one bit and expanding in another bit, so-called atrophy when it gets small and hypertrophy when it gets big. So staging should be going on in clinic, because it should be telling you as a doctor and for the patient, how is my patient doing? And is my patient transitioning to a more advanced stage of disease where I need to start talking to them about some things that could start to happen in the years to come or months to come? And also to give the patient, which is quite nice for some, reassurance that you're at the good end of the spectrum. So the answer is yes, it's part of guidelines, different ways of doing it, and should be done intermittently.
Thanks very much for that. I hope you can't hear a herd of elephants that are upstairs in my house, but I'll carry on and ask the questions anyway. And this is a question that does occur for people, particularly when they're newly diagnosed, and can be
Mm,
very scary.
mm.
What's the life expectancy of someone who's got small duct PSC, and how quickly does it progress?
Yeah, no, it's a good question. I think so. I mean, I often go back, if we just take the answer of PSC in general. I mean, as people often read on the internet, years ago when I did the clinic when I was at Cambridge, when I was a registrar, I used to have some spiel about, on the same internet spiel about how it was a disease of, people used to come and go, I really got 12 years to live. They used to read on various formats, and then we knew that the reason why all this bad data was out there is because, well, essentially, all the big centers that had all the bad patients in terms of advanced disease were telling the world what their patients were doing. But of course, when you went to, what they forgot is that the patients at the good end of the spectrum weren't going to those clinics, and therefore they weren't represented in those natural history studies. So then came along people like the Dutch group and others who took a much global view. They reported on all their patients. And as you know from those papers, for example, I mean, the last really, and a very good paper was published by Cyril Pension in 2016, I believe, that really showed that the average life, 50% of people were alive and doing very well at 20 years. Now, I think it's hard to say that was all comers, that was all people. Okay, but as you allude to, we think small duct PSC does have a much milder phenotype, i.e., it doesn't progress as quickly. And certainly, we don't think those patients have an elevated risk or a much lower risk of HBB cancer, i.e., the development of cancer. So, overall, we think small duct PSC does do a lot better. I think it's hard to give you exact figures because I'm not really sure I know of any data that tells you specifically for that cohort. But I would say to you, they are often in those patients that have done very well. And as I say, the median, where 50% of patients are doing very well at 20 years, are often inclusive of them. The major thing is really making sure someone doesn't transition from small to large duct, as perhaps they were also alluding to in that question. And that's why you do need to do a regular MRCP, maybe every 3 to 5 years. It depends where you work. There's no guidance on it. Everyone has their own ways. But the idea is you just have a look again, because maybe 7 to 11, 12% of people will transition from small duct to large duct. And that might alter a little bit those discussions in clinic, the potential complications that can occur and things that the patient should look out for.
And again, when somebody is newly diagnosed, doctors will often talk about a liver transplant as being one option if the disease progresses in that way. Does it always, the question is, does it always result in needing a liver transplant?
And for the reasons I said, when you look at those natural history studies that include the bad patients and the good patients in terms of who's at the good end of the spectrum and the bad end of the spectrum, those good end of the spectrum patients hadn't had a transplant at 20 years. They're 50% are well and alive and haven't had a complication. So I think it's really hard, and this is part of the problem of when you're telling people about this diagnosis, is you don't want to overload them. I think you do need to sometimes work out where you think that patient is at the start of their journey. For example, if you're diagnosing a patient that's got a very high ALK phos, which is a marker of bile duct damage, and showing other concerning features such as a low albumin, they're mildly jaundiced, the liver looks very bumpy, of course you feel that patient might progress potentially to that situation quicker. But equally, you've got patients that got very mild scarring, very low blood tests, and doing very well. So the honest answer is no, not everyone progresses to a transplant. That is the bottom line. Okay. And a lot of patients will never need a transplant. Okay. And that's an important message to remember.
Thank you for that. So we have a question here about jaundice. What should you do if the PSC patient suddenly shows signs of jaundice, yellow eyes
Okay.
and skin, should you have urgent blood tests?
Yeah, so I think the first thing is always to go to see your GP rapidly. Hopefully, you've got a way into your specialist through your specialist nurse and let them know there's been a rapid change. I think the first thing is to confirm it, to make sure what you think you have is jaundice is correct. So that would mean some blood tests with the GP. And then I think you need to do a number of things quite quickly. Yeah, you need to review your history, a medical specialist, to make sure there's nothing else that's happened, like you've taken a drug that could have caused jaundice. You need to go through those little things. But let's assume that you think it's from PSC. The normal first thing is really getting some up-to-date imaging, okay? And really what you want to be rapidly transitioned into having some imaging to see why is something changed, okay? Is it due to a stone? Is it due to a new narrowing in the bile duct? Could it be something more serious? Or more importantly, is it just the fact that the liver's not working as well? Is this the beginnings of a liver transitioning from a patient potentially needing a transplant? So many things to think about, but the bottom line is jaundice is one of those things that we want to hear about if it happens to patients. And of course, it really does demand quite urgent investigations, and also to make sure you understand why it's happened and how you manage it. So yeah, you must report it. GP and specialist is the bottom line, and confirm it on a blood test.
Go straight away if that is occurring to
Yeah, no,
anybody.
straight away.
Question here about your SAVOR PSC trial.
Oh right, yeah. I've done
Yeah.
by a mirror, yeah.
Yes, in your university hospital.
Mm.
Brodalumab, which is used for psoriasis, targets
Hmm.
IL-17 in the body. I know you know this.
Mm.
Should PSC patients be screened for IL-17 in blood tests?
The answer is no, because if I measured your blood tests and all the proteins in your blood tests, sorry, all the proteins in your blood, lots of them would be altered in PSC, and there are many proteins that are produced by the immune system. Um, the reason why we think this might be important, and the reason why Amir is doing this NHR fellowship, is because there is a lot of data suggesting that the IL-17 pathway, and these what we're really saying is the immune cells are producing chemicals which can damage the bile duct cells and cause inflammation. That if we think that, perhaps if we could block that pathway, it might reduce the inflammation and be of benefit to patients who are early in their journey with inflammation in the liver and the bile tubes. So I certainly wouldn't advocate having a protein measurement of IL-17 in your blood, because there are lots of different inflammatory proteins that go up in PSC in your blood. But this is more to do with some of the mechanistic science that's been undertaken in PSC and animal model work that suggests that that inflammatory pathway might be important, i.e. the immune cells might be making lots of IL-17, and therefore if we block it, it might be of some benefit. And obviously Amira's a study that she's doing is really looking first of all at the safety of that. We're understanding, is it safe to give to patients? And then if we get a positive safety signal, then it's hopefully a study that she'll take forward to do in a proper, more controlled way to ultimately determine, does this therapy help in PSC or not? And I suppose that links back a little bit to the vancomycin question. We couldn't just give this to patients and see some benefit and think, oh, that works. You've always got to do it. You've got to have safety first, and then a mechanistic understanding in the right sort of trial. Does this help? Which I know is incredibly difficult in PSC. It's the thing we all struggle with, how best to do clinical trials. But you need to know it's safe and you need to know its efficacy. But it has a good rationale for potentially working. And I hope, as you saw a little bit with all those drugs in inflammatory bowel on my slides, for me, this is the hope that one of these targeted proteins might have a beneficial effect if we can turn off that overactive immune system.
Potentially very exciting trial that. So this is a horrifying question for me and for everybody, and for you too, I'm sure. I seem to have been told my diagnosis, had improved bloods, and now I've been left to, and the person quotes, Google it. So they've been told by their hospital to Google PSC, which we tell everybody not to Google PSC because
No.
the information is very scary. So the question is, what support could I expect from the hospital? Sorry, the information is not just scary, but it's incorrect on a lot of the Google pages.
I think it's, I know I mean, we all know care, and we all know clinic interactions are very variable. I see that in many places. I think the first thing is that's clearly incorrect. You as a patient, you have a right to high quality, correct and factual information. And for me, that's one of the joys of working with PSC support. There is a huge amount of medical literature on there that has been checked by people like myself, Gideon Hirschfield, Palek Trivedi, and others to make sure that information is factually correct. So I think that's where, and it's true for all diseases, you want to go to a reputable charity with medically checked information so you get the correct information you need to a level you want as well, where you can dip in and out of sections of the information that you may be ready to hear or not ready to hear. I think if you feel that your specialist isn't able to answer your questions or give you the care that you deserve and need, then maybe you need to ask to see someone else. The problem is with all rare diseases, we all know a lot about what we know about, and if this is an individual who only has a couple of patients, it's sometimes very difficult to answer patients' questions because often a patient can become more rapidly knowledgeable than their specialist. So that's where going to a centre where you see people, as once again is shown on the PSC support website, and seeing people who know a lot about the disease is helpful. But I would hope that going to PSC support and using their medical information would be a good start for you. And you shouldn't certainly be allowed to flick through random papers where it can be quite scary, difficult to navigate, and you could be very much left with the wrong impression about certain risks of PSC and how they could occur in you.
Thanks for that. So I'm going to finish with this question. And it's a question about younger people and the potential progression of the disease. Is it common for younger people to progress quicker? It seems to be the case in the PSC group. I presume the poster is talking about our private Facebook group, although of course those doing well may not interact with the group. I would say younger people don't interact with that group as a general rule either, so it might be skewing the vision of that.
Yeah, I mean, once again, I think it's funny, isn't it? Because when you do all these natural history studies, interestingly, age, i.e., the more old you are, tends to be a negative factor. But that's probably just, it makes sense because the longer you've had something, the more likely it is. I think what I would say to you is, even within young patients, I have a completely heterogeneous, which means very different group. I have patients that are very well with no scarring, their alk phos is very low, they have very mild disease, and then we have groups of patients that are progressing. And I think really, if you go to some of the pediatric literature, and actually, you have to really take your hat off to North America, who have done a huge amount of work here. What am I trying to say? Collect large numbers of patients. I sort of get a feeling when you read those papers, they're a bit like the adult population. A group, we can talk about numbers, a third or something, seem to have a more progressive course, but there is a group that do very well. And that is in large cohort data. So I suppose what I'm saying is the pediatric group, in my mind, mirror the adult group. There is a group of patients within there that will progress sadly quicker, but there's also a group that do very well. And in some of those papers, you could use certain things to spot those ones that were doing well. But if you're really interested, there's some really good data from the North American group that I would recommend you read. And yeah.
Thank you very much. I think that was a really fantastic session. People are putting their thumbs up again. Really clear answers, and I hope we've not been able to ask all the questions and answer all the questions, but I hope that we've been able to answer, well, we've been able to answer as many questions as we possibly can. There's some comments in the question and answer session to say, fantastic talk. Thank you so much. That was amazing. So again, Dr. Simon Rushbrook, thank you very much for your time tonight. Our next session, our next Ask the Expert is on the 25th of June with Dr. Emma Culver reporting back the findings from the recent European Liver Conference, which myself and Martine from PSC Support will also be attending and reporting back anything that we find too. But join us on the 25th of June for Dr. Emma Culver and Dr. Rushbrook and everybody out there. Thank you so much for joining us tonight.
You're welcome. Thank you.
Bye-bye.
Bye-bye.